Okay, in this session we're going to cover prenatal genetic testing of fetuses in utero. We're going to look at the sort of diseases that can be tested in utero, also what can't be tested for. And we're going to look at some of the ethical issues associated with this, because obviously you can't just test for anything that you want in utero. There has to be a very good clinical reason for what we're testing for. So after this session you should hopefully be able to describe the sorts of diseases that can be tested for by prenatal genetic diagnosis. And in answering that type of question, you'd also be able to explain what can't be tested for, and be able to explain why certain things can be tested and why other things can't be tested for. You'd also be able to explain the ethical issues that have gone into deciding what is allowed to be tested and what is not allowed to be tested, and look at the sorts of decisions that are made, some of the factors that are considered, such as the parents, the fetus, society in general. So we're going to look at that from an ethical point of view. And we're also going to look at the legal issue of performing prenatal genetic tests, because you have to be a registered lab to be able to do this type of work, doing a test that is registered to be approved for prenatal purposes. So we know that prenatal testing for congenital diseases can occur. Last week we looked at routine for things like Down syndrome. So Down syndrome is a genetic condition. It's a condition that occurs in utero, as in due to a defective egg or a sperm. And if we do scans, so we saw last week scans which identify potential Down syndrome by a chemical test such as alpha-fetoprotein, which may indicate Down syndrome as well. If those show raised levels or suggestion of Down syndrome, then a genetic test for Down syndrome is possible. So these genetic tests are performed using either chorionic villus biopsy or amniocentesis, as we saw last week. Chorionic villus biopsy sort of 11 to 15 weeks, amnios sort of 16 weeks, that sort of time frame. The timing of these allow tests to be performed to allow termination of affected fetus if the parents choose to do so. Now when we're talking about hereditary diseases, these are different in that we are expecting them to be present in carriers or affected people. So when we're looking at genetic diseases where we know the parent's got a genetic disease, we know the frequency of that in the offspring, we can then look for that specific mutation that's present in the parent in the fetus to confirm whether or not the fetus is diseased. So if we're looking for a mutation in the fetus in utero, the favoured route of testing will be a chorionic villus biopsy, and that's because you can have the earlier date for detecting the genetic abnormalities, so testing from 11 weeks onwards. That also then allows an earlier date of termination. Now, if you know that you are a carrier of, say, cystic fibrosis, and so is your partner, then those sorts of people in that situation would go for a chorionic villus biopsy at the earliest possible opportunity. This is why a CVB is usually done rather than an amniocentesis. Whereas with Down syndrome, it's often a amniocentesis, or as we're going to find out in a few weeks, non-invasive blood tests. But that's because we're only finding out there's a risk of Down syndrome maybe at a 16-week scan. So we've got to consider what sort of genetic diseases are suitable for testing in utero, and certainly not all things can be tested. And what we want to do is get you to have a little think about what sort of diseases are severe enough to warrant a termination taking place, and what diseases are not severe enough and maybe would be considered mild traits or diseases that don't cause excessive amounts of suffering. So you can probably predict that some of the really well-known major genetic diseases would be tested for, but some of the ones that you maybe think are quite mild may surprise you about whether they can be used to test and then on that basis perform a termination. So it's fair to say that mild traits are not permitted. We'll discuss what mild traits are shortly, and neither is sex testing usually, unless there's a very specific clinical need to perform that. So what I want you to consider are the following 5 genetic diseases or changes, and think, are these suitable diseases that we would like to test for to allow parents to then terminate that fetus if they knew they had that disease. So Duchenne muscular dystrophy is a lethal degenerative muscle wasting disease. Typically patients will die in their 20s, although sometimes if it's the slightly more mild Becker muscular dystrophy, patients may live into the 40s. It's X-linked, so it only affects boys. Now this might be important if we're maybe selectively terminating boys, which we'll come on to later. Female carriers are unaffected, but they do pass on that disease to half of their male offspring. So the question is, what sort of things could be tested for? Should we sex test before mutation screening and maybe allow female carriers to be born but terminate all boys? That is a possibility if you don't know what the mutation is, but we need to consider the mutations at some point. But if we do find that a female is a carrier of Duchenne muscular dystrophy, what are we going to do with that information? So have a little think. Do you think that if you're going to test for Duchenne muscular dystrophy in a fetus, is it worth testing for a female to find out if it is a carrier, or do you just test the sex of the fetus first, and if it's a male, then test for the mutation? So those are the sorts of things that you might want to consider, because some of those possibilities might be allowed, some might not be allowed. Similarly, we've got a disease down here, hereditary melanoma. It's caused by a mutation of the P16 gene, which you'll learn about next year. It causes this familial atypical mole and melanoma syndrome, where you've got 20 to 30% of melanoma by the age of 40. Now this disease is probably more common than we think living in countries like the UK with not quite as much sunlight, but it seems to be overly prevalent in places like Australia where there's lots of sunlight. Now the risk of disease can be near enough completely reduced by avoiding sunlight throughout life. So is that something that you think should be allowed to be terminated? It is a hereditary cancer syndrome. However, it is entirely preventable. We then got cystic fibrosis, autosomal recessive disease. We have maybe 1 in 20, 1 in 25 people in the UK are carriers of this. So maybe 1 in 800, 1 in 1,000 births, something along those lines. You get a build-up of mucus in the lungs, repeated lung infection, and without extensive treatment of things like lung transplants, death in early 20s or 30s. Colour blindness, it is, I suppose, a registered disease. Really, just about the only thing you can't do if you are colourblind is operate certain types of machinery. Join the RAF, you can't be a pilot, you can't see, red or green contrast. So apart from that, you live an entirely normal life. And then we've got late onset Alzheimer's disease risk factor. Now, this is just a gene called the apolipoprotein E gene. There are 3 different common alleles. If you've got the high risk one, you're 10 times higher risk than the general population of late onset Alzheimer's in your 80s. So do you think that will be the sort of thing that we want to genetically expunge from the population? Okay, so consider the P16 hereditary melanoma disease. Now consider hereditary breast cancer. We have 2 types, BRCA1 and BRCA2. Hereditary breast cancer, BRCA1 and BRCA2, they're both autosomal dominant. The sorts of things that you might be offered to prevent the cancer from forming is a double mastectomy in your 30s, maybe also a hysterectomy, because this can also give rise to tumours of the ovary and endometrium. So technically you could have hereditary breast cancer with a 50-60% chance of developing breast cancer, but equally you may well be able to prevent that cancer by having elective surgery. So I think, is that the sort of thing that you could would be justified in performing a termination for. Now we've got other diseases such as hereditary blindness, optic atrophy 1, where you get moderate to severe vision loss, autosomal dominant, so certain blindness. And that can be either early in life or late in life. Early onset Alzheimer's disease, sorry, the bottom of that's missing. This is an autosomal dominant disease where you are certain to develop Alzheimer's disease maybe in your early 50s with death in early 60s. And this is different to late onset Alzheimer's disease. It's a neurological condition that has a definite genetic basis to it. So if you've got this, you are certain to suffer from that disease from the age of 50-ish onwards. Now, phenylketonuria is a tricky one because it's autosomal recessive, it's a metabolic disease. If you eat the wrong diet, which is we've got a source of phenylalanine in it, that can cause neurotoxicity, mental retardation and seizures. So it is a disease that causes really significant problems to people who are affected with it if they don't have the right diet. However, they are entirely treatable, so with the right diet, symptoms from this will be near enough non-existent. However, that is dependent upon the parents not having suffered it themselves. And if you've got parents who have suffered from problems of phenylketonuria and the neurotoxicity, then are those patients going to be, those parents, but the best people to prevent this from happening by giving their child the right treatment and diet and so on. So this is a weird one in that it's entirely preventable, but maybe because many parents are not able to prevent the disease, maybe it should be considered a severe disease. And then finally we've got Huntington's disease, a very severe autosomal dominant disease, age of onset 40 to 60, patients will die within 10 years, they will be incapacitated for the last few years of life with very limited ability to move and do very, they'll be doing very little for themselves. And they pass this gene on to half of all offspring before their own symptoms develop, which is quite unfortunate because previously patients would like to have known if they were affected before they reproduced, and that would make a decision. Now they can be tested, but there are lots of people who don't know they've got this and will find out they've got it maybe while they are expecting. So what I want you to do next, having looked at those diseases, pick 2 of those diseases and fill in this, which is called an ethical matrix. And this looks at the main interest groups, which is either the patients themselves, clinicians and scientists, the embryo and society, and what I should say, in this case patients being parents, the embryo being the affected embryo, but look at them and think about how that disease will either affect the parents of the affected child, the embryo itself as it develops into is it after birth, is it going to suffer excessively? Think about the clinicians and scientists. Is it ethical for them to perform this genetic test and this termination? Is that in keeping with the Hippocratic Oath? And you've got to also think about society. And this is a really interesting one because society has got to support and look after any people who have serious genetic diseases. So we know that if we are allowing somebody to be born with, say, Down syndrome, society will be looking after that. So does society have a role in deciding whether this should happen? Is it fair that the embryo should be allowed to be brought into the world? And if you've dealt with children with severe genetic diseases, sometimes they will ask the question, why was I allowed to be born? Because they are suffering so much. So you've got to think, is it right that the child was born in the first place? But if it's so severe? So basically what I want you to do is fill in a table like this using the last slide on the presentation for 2 different genetic diseases and consider the relative benefits of testing for this disease in utero versus not testing for this disease, and then decide whether you think that that particular genetic disease would be on the approved list for genetic testing in utero.